First thing is to analyze what we call the intra-articular lower limb discrepancy. So we are dealing now with the left hip, and you can see here we use quite standard landmarks. So the teardrop here, and here the teardrop, and here I use usually the middle of the lesser trochanter. And you can see that this patient don't have any kind of lower limb discrepancy. Of course, it's an AVN, this is why. But you can see that on the other side, he has a decrease in the femoral offset relatively to the contralateral normal hip. Afterwards, we have to analyze the segmental length. So for the segmental length, you have the top of the great trochanter, the middle of the knee, and the middle of the ankle. And you can see here that the limitations of the 2D analysis, because basically it would be much more precise to do it 3D, but in current practice at the moment with this HipPLAN, it's easier to do it 2D. So you can see here that basically the patient, it's +1, which means that he has exactly the same length on both sides. So I would aim in this patient for zero lengthening and no modification of the femoral offset. However, for the femoral offset, we will analyze this later on in 3D. Afterwards, we have to analyze here the bone density. You can see that he has a good. He seems to have a good bone density here, about 148. The average is about 90 to 95. So when we are at 150, it means that it's a hard bone. It means we really have to hit it quite strongly with the hammer. When we are above 200, it means that we need probably a motorized reaming procedure. And as he told us, our colleague told us just beforehand, I would use, like the trauma ones, I would use the flexible reamers because it's much easier, and if needed, we can use a guide, a flexible guide, in order to find the femoral axis. So afterwards, here we analyze the knee also to get the referential for the femoral offset for the femoral anteversion. Okay. Afterwards, here, first step is to go to analyze the acetabulum. So you can see here, the first step is to determine what would be the goals. So the goals, basically, we use what we call the acetabular sphere here. And the acetabular sphere, we just have to position it within the acetabulum. It's exactly what we do when we navigate a hip, and we just use a trial cup, and we put it inside the acetabulum just to determine what would be the optimal size and what would be the center of rotation of the hip. We do the same thing, but with this. Okay, let's hide this. That's it. With this 3D template. And you can see here that we can analyze quite accurately the native anteversion of the acetabulum. Okay? And we can see that the anteversion of the cup here, of the acetabulum, is about 19. You can see here it's about 19 degrees. So quite standard. And the acetabular diameter is about 55 54, between 55 millimeters. So usually I would test either a 56 or a 54, it depends. That's it. 54 or 56. And here you can see how the cup would be positioned. And I will go for 44 and not a 46, because if we use a 46, we may have some kind of psoas impingement here. So I would say I will go for 44, and you can see here that I will tend to restore the native anteversion of the patient in this case. Now here also the color mode that allowed us to see that this position will be stable, because we have hard bone on the two horns and somewhere here on the roof. Here it's not really hard because the native acetabulum is about 55 degrees, so we will implant it with a lower inclination angle, especially because we use ceramic, alumina ceramic. Okay, once we are happy with the cup, we go to what we call the femur frame, and you can see that this femur frame allows us to analyze the femur simultaneously in both the coronal view and the sagittal view, and also the axial view. So I like to use this color mode because basically it allows us to see the limits between the cancellous bone and the cortical. So let's go back now to this. Afterwards, we always have to take some landmarks. So you can see here, for example, you can see here the lesser trochanter. So you can do it in the like I'm doing it, manually, or you can go directly here in 3D and just pick up the points. For example, if you want to pick up the top of the lesser trochanter, just do it this way, and you will get it. Okay, you can get also the top of the great trochanter like this. Okay, and once we have our femur frame and we have our landmarks, which means the digital fossa here, the top of the lesser trochanter, the top of the great trochanter, we can start simulating the stem implantation. So for example, here is a quite young patient with good corticals, with a very good bone density, with a flare, with an anterior flare. I would go for an anatomic stem at the first glance. So anatomic SPS evolution, okay. And here you can see that we always try to position the stem aligned with the mechanical axis of the femur. And you can see that in this case, we have a quite good fit at the proximal part of the femur. And you can see here this red part on the map. And when you try to analyze what this red corresponds to, you can see here that there is a spur. You have to be very cautious with this spur. This spur, in my experience, we find it especially in the various cases, and especially when patients with a very hard bone. So usually you don't see it, especially when you brush with the standard straight stem, you don't see it. If you really want to see it, you have to look for it, and sometimes even you can use a scope. I did it once. With the scope you can see it very well, because I do also some hip scopes, this is why. And sometimes it's so hard, it prevents from implanting correctly the stem. So from time to time you have to need to use a curette just remove this spur in order to be sure that the stem will be fitted like this. So this is why what I would do, and when we analyze here what would be the final correction done for this patient, it will be +2, 0. It means that there will be a lengthening of 2 millimeters and no alteration of the global offset of this hip. So for me, this is okay. I will go for this. And I can show you, I have the video of this patient running at 3 months with no problem. He's doing extremely well. So this is a quite standard hip. But I think the 3D planning is very important because we know that it's a hard bone. I have prepared in my surgical theater a reaming procedure, motorized reaming procedure. I know that there's this problem of the spur. Maybe I will have to use a curette to remove the spur. There's also another thing I did not tell you about, is this. Time to time here, at the anterior part of the anterior and lateral part of the femur, we may have some very, very hard bones. When it's red like this, it means it's something like 400, 500 units unity. And sometimes, some cases, this may prevent you to position correctly the stem. It will tend to increase the femoral anteversion. Sometimes I will just try to remove with the curette this bone. It's quite rare, but you know, we are looking for the outliers that will, the 5% of patients that will create the 95% of complications, you know. Do you have any question about this, I would say, simple case? A 3D planning for a simple case, it takes between 5 and 10 minutes. Not much more than, not much more than, I would say, a digital templating. If you have no question now, I will go forward for a more complicated case. Let's go for which one? Yeah, let's say this one, yeah. This guy is not so young, but he looks very young. Yeah. He was, I think, 55 or quite extremely active guy. So when we analyze the scout view, obviously this guy, to be honest, at the beginning I did not notice that it was a so huge coxavara. For me, it was a quite standard hip. But however, it looks quite bizarre, you know. It looks coxavara. When we measure the CCD angle on the X-rays, it's not so coxavara, but it looks coxavara. And this patient, basically, when we analyzed the intra-articular length, this is the teardrops, okay. Whoa. The teardrops, okay. The left side trochanter, the middle of the left side trochanter. And basically, there is no major lower limb discrepancy. Maybe a slight discrepancy because of the wear. And when we analyze the segmental length, here, the top of the great trochanter, even the knee is in vara. Everything is in vara in this guy. And the ankles, you can see that this guy has no major lower limb discrepancy. It's -1 and 0, and -1 inside the joint. It means that he's perfectly equal. So this guy, you have to be very careful because he will not tolerate so much a huge lengthening. No, now let's go to the here to analyze the bone density, and the bone density is 262. Wow. For sure, I will prepare for this patient a reaming procedure, motorized reaming procedure with the flexible reamers, and probably I will use also a guide, a flexible guide, in order to be sure that to be inside the femur. It's very easy, especially when we use direct anterior approach, whatever it is, on traction table or standard table. It's very easy to have a force root in such a case. Now the BCP angle, okay, the bicondylar plane to have the reference for the anteversion. And at the beginning, I tried first an SPS evolution stem because active guy, very good bone quality, and you will see now it's kind of a flute, champagne flute femur. So basically, for the acetabulum, there was no big issue for the acetabulum. Okay, and I planned a cup. It was a 52 millimeters cup with no big problems. Always the same thing. I'm very careful sometimes. I go for a smaller cup just to be sure to avoid any kinds of psoas impingement at the anterior part. This is one of the big issues in these patients. And afterwards, when we try to analyze in the femur frame here, you can see many things. First of all, he has really high flare and very thick corticals, and in my experience in these patients, the Corai-like stems, or let's say the Mueller straight stems, don't do so good because we may have a distal fixation with, when we analyze, we assess patients at, I would say, 1 year follow-up, they will start to have some kind of lucencies here in the zone 1 and 7. It means that basically the stem is doing something like this. It's okay, they will do okay, they will be happy, but we start having some troubles at 6-7 years follow-up. So in my experience, when we have really these door A femurs, not the door classification analyzes on X-rays, but we can have the same thinking in the coronal plane, but also in the sagittal plane. So it's a high flare, including in the sagittal view. And this is really much more difficult to deal with. For example, when getting out, when someone is sitting and stands up, this is where we'll start to have maximal constraints now. And this sagittal stability is very important. So when we use this SPS stem, basically, the biggest stem we could implant in this guy is a C SPS evolution. It will be stable, no problem. You know, very nice stability here, very nice fit and fill in the proximal part of the femur, except maybe here in the sagittal view. But when we analyze the density of the bone which is in contact with the stem, this stem will be stable. I'm not afraid at all. The problem is this guy, when we analyze the alteration of the hip anatomy, we have 4 millimeters of lengthening. It's more or less okay. But 12 millimeters of decrease in the global offset. And this really annoys me a lot. For -12, it means he will dislocate even when using an anterior approach. So in this case, we will tend to use a +4 or a +8, which means that we will reach a 1 centimeter lengthening on this side. So first possibility to do this, to go for a lengthening of 1 centimeter, to announce this to the patient. You have to announce it very clearly, to write it on the medical observation, and to avoid any kind of legal action afterwards. And if the patient is okay with this, we can go. Otherwise, in this case, also because he was very young, I prefer to go for a custom stem. What's going on? Probably doesn't manage to find the custom because I don't know why. Let's say launch it again. Yes, that's it. This is how we can position a custom stem within the femur. But I think it's not the correct. I have a bug with my, I don't know what's going on. But finally, I used, because no, it's not the correct one. It's not this one. No. Yes, that's it. Okay. So we can see now how the custom looks like. We can understand now how it works. So we can keep the various morphotype, optimize the fit and fill of the whole stem, and also to how to correct he had a slight, yes, can you see this? He has a slight retroversion of the neck relatively to, yes. There is a retroversion of the neck relatively to the metaphyseal part of the stem. So it's not only a matter of femoral offset, it's also a matter of rotational stability and also of antiversional restoration. Because in my experience, the best results in young patients is when we manage to balance the external rotation and the internal rotation. And it's very difficult to assess at the time of surgery. And this is why now I'm stopping using the traction table for the direct anterior approach, and I'm using a standard table because of this. Because on the traction table, we're not able to test correctly the edge loading. It's not a matter of dislocation, it's a matter of edge loading. And this is why, with these customs, with these retroverted necks, we are able to test and to really to assess the fact that we have a balance between the external rotation and internal rotation. Any question, maybe? Okay, so let's finish with the final case, final DDH. This one, yeah, very interesting, this one. She's a very young lady. Very interesting because at the first glance, what we can see here at the first glance is that this patient, it's not a dislocated hip. It sounds, we can see that there is the femur is narrow, it's true. But to be honest, before analyzing the CT scan, I was not so worried about this patient. It's true, I saw that she had some kind of unbalance between the external rotation and internal rotation. But I was not aware of how difficult would be this case. And this is why I always do a 3D planning in all my patients. It's a way to screen now. And very interesting because when we analyze this, we can see that there is obviously lower limb discrepancy, but a very important part of this lower limb discrepancy is because she has a fixed adduction of the hip, which means that when we will implant the hip, the prosthesis, and this patient will have an abduction, a huge part of this lower limb discrepancy will disappear. And also in these patients, I always perform an assessment of the spine, because obviously she has a pelvic obliquity. And this pelvic obliquity, maybe it's due to the fact that she has a fixed adduction, but maybe also it may be fixed because she may have a scoliosis and a spine deformity. So I always do also a spine assessment, and in this case, the pelvic obliquity was not fixed in the spine. It was really related to the hip. So in this case, we can go for a lengthening. Otherwise, no. For the monolateral side here now, it's very interesting because we can analyze this. For sure, the hip is not dislocated, it's true, but you can see that there is a huge difference between anteversion here and Hedi torsion here. If you follow the Hedi torsion, the head will be somewhere here, and for sure it will dislocate. Okay? It's nearly sure it will dislocate, or at least we will have huge edge loading and sub-dislocation all the time. Regarding the bone density, I think it was correct. 141, of course. 140, she's a young lady. Okay, the bicondylar plane. Now, if we go to the acetabular position, it was 40 millimeters cup. Of course, it's a dysplasia. So this is very interesting because in the 3D planning, we can forecast, anticipate the diameter. And for example, very few companies have a 40 millimeters diameter cup with ceramic in it. So it's very important to get. And these very small cups, sometimes we don't find them on the shelf. We have to order for them. It's very rare. Okay, nothing special. And you can see here that despite the fact it's a very small cup, it will be not so complicated to achieve the cup stability. But what we can see here is that it's a difficult case because it's a small cup, and the reaming procedure has really to be accurate at the beginning. We have to get it right at the first glance. If we, for example, we start to ream too much anteriorly, and this is what happens usually when we are with the minimal invasive direct anterior approach, it's very easy to remove the whole anterior horn, and afterwards it will be nearly impossible to stabilize, to make the cup stable. So afterwards now, go to the femur frame. Okay, you have the solution directly, but if let's say that we want to try, I don't know, an anatomic stem, of course it will be too big, of course. But do it just for the fun. Okay, it will be too big, and basically not feasible. We may really have fracture. Let's try, for example, now a standard harmony, which is a standard stem. Let's say the smallest one, the 8. And even the 8, in my opinion, is not feasible. It's not feasible. And even if we try with a reamer, no. We try to make it here bigger. There will be huge problem with the length. Because in this case, for example, we are going for nearly a 40 millimeters lengthening. So this is why, of course, I choose a custom. Oh. Now, for the custom, I have to launch it again. I don't know what's going on with these customs, but because it's not the same, they don't use the same software to design the custom. This is why. So when we analyze here the stem, you can see that we managed to get a correct fit. And anyway, we will need to ream here the distal part to be sure, not to be able to implant the stem, but to be sure that the stem will be seated where it's designed to be seated. It's not a matter of stability, of matter of pain, it's a matter of bone remodeling. So 3D planning is between 5 and 10 minutes. If it takes us more than 5 or 10 minutes to do it, it means that it's better to stay half an hour analyzing the case, because there is something wrong going on. Either coxavara, small femur dysplasia, and mild dysplasia. We are dealing more and more now with mild dysplasia. Coxavara, antitorsa, long necks, very long necks, and all this, very high flare. I would say the door A in the coronal or in the sagittal view. Sometimes you have very wide femurs in the sagittal plane, or sometimes you may have some round femurs, completely round, even in young patients, round femurs. How could we stabilize something straight and completely flat in something completely round? If you have any questions.
If you have a patient with a valgus femoral neck with reduced offset and you want to normalize that offset, how far can you push that femur out laterally before you get concerned of increased soft tissue tension?
To be honest, I always avoid to increase the femoral offset. So I will not tend to increase it. I will leave it with his or her morphotype, especially the valgus in women. The valgus in women, especially when they are over 50, they don't tolerate at all any kind of increase in the femoral offset, especially if there is a lengthening. So I would say if there is a lengthening, there is a lengthening of, I don't know, X millimeters, I will tend to decrease the femoral offset. Not femoral offset, I will tend to decrease the global offset by the same amount. If I do +5, it's better to go to -5. But once it depends on the case. We really have to enter in the 3D anatomy of the femur and analyze what's going on. You know what I mean? If there is for example, if we need to lengthen the limb, it means that maybe there is a wear that put the hip slightly subdislocated laterally. So it means that we have to do this and this to put it right again. This is what we call here. Can I see this or not? Ça marche quand je fais ça? No. In this? No. Okay. Here, this table is very important. There is what we call the initial displacement. The initial displacement basically is what is related to the wear. Let's suppose that we are able to say exactly where was the center of the femoral head before the disease and where was the center of the acetabulum before the disease. So normally, these 2 points in a normal hip should be coincident. Because of the wear, they will not be coincident. So there will be what we call initial displacement. Let's say a wear with a shortening and a slight shift laterally. Afterwards, we have the femoral head displacement and the acetabular displacement. Basically, this is what is due to our surgery. Because of the reaming procedure, we will alter the position of the center of rotation, so we will induce an acetabular displacement. Usually, it's a shortening, posterior shift, and medial shift. Usually we always ream the same way, posteriorly, cranially, and medially. But we try to compensate for this acetabular displacement by a femoral head displacement. For example, here, there is a lengthening, an increase in the femoral offset, and a shift posteriorly because there is this retroversion on the neck. So what we are aiming for, basically, is to get AD plus AFHD equals 0. It means the alteration of the acetabulum center of rotation is perfectly compensated by what we will do on the femoral side. So to answer to your question, it's difficult to say, generally speaking, what I would do, but in this case, I will keep the valgus morphotype, not increase the femoral offset for sure, and sometimes, if there's a lengthening, do some kind of decrease in the global offset. But once time more, it depends on the case. I hope I answered to your question.
Often the plans that come back from Symbios, if someone has a particularly reduced, abnormally short lateral offset, the plan will come back with an increased offset towards normalization. But the penalty of that is increased soft tissue tension laterally. And there's clearly a sweet spot where one gets a better offset in terms of mechanics and wear, but without the penalty of the soft tissue tension being increased. And it's just what your thoughts on where that sweet spot was.
The problem also that there are some kind of industrial constraints. We cannot design anything. It has to resist to the fatigue tests. So this is why they are limited in their range of design. So I would like to see these cases, but to increase the femoral offset on the valgus, we really need either it's a very, very strong valgus. It means sometimes, I don't know, 15 millimeters femoral offset. This kind of candle, these candle femurs, quite rare, but maybe. But I would say in a quite standard valgus femur, I would really ask for a zero alteration of no increase, at least no increase. I would be really interested to see this case. When we start speaking about outliers, we really need to go into the details and see in the 3D planning what's going on.
Great. Thank you very much for your insight into hip planning.